if Rob Webster is here, if he'd like to come up to the platform as well. I can't. Oh, sorry, you're hanging around there. Thank you so much for the 3 speeches, and it's a very fertile ground. I was just wondering, kindly, where that professor of sociology was.
She's the University of Greenwich. It's Professor Tracy Reynolds.
Okay. Can I welcome to the stage Rob Webster? He is, you probably all know anyway, Chief Executive of the NHS Confederation, as formerly was at the Department of Health, and has been a Chief Executive in the NHS, and we're very grateful to you for joining our panel. I was thinking about things that have changed in the past year, and one of them is that I now need my glasses to see when you put your hands up. So we will open the floor to you, and I'm assuming that there are microphones. Yes, I can see them wandering around. So if we could have your questions, please, to our panel. There must be some out there for all of them. Oh, sorry, round the corner, yes. If you can also say where you are, who you are and where you're from, that would be very helpful.
Hello, I'm Dr. Deep Saror from Derbyshire. There was a presentation on the statistics behind BME health inequalities. I was just wondering how much research is out there which is fully adjusted for socioeconomic confounders, and if there is, what amount of influence that has specific to BME groups.
Would you like to?
Sure. So thank you very much for that question. Over time, I'm pleased to say that the research and the research methodology has evolved so that those of us who are doing research in looking at variations in health outcomes now adjust, if they're epidemiological studies, for a range of confounding factors, of which social background and economic background, social economic status is certainly one of them. So in general, more recent studies tend to adjust for it because we realize the powerful effect it has. And while socioeconomic status can attenuate the impact or the differences that you see, they do not entirely remove them. And that's because there are other determinants which are acting as well, such as behavior, culture, attitudes, etc., as well as factors around the system itself. So socioeconomic circumstance, it remains a powerful determinant, but it is not it doesn't entirely explain the variations that we see. A lot of my early research was in HIV and sexual health, and looking at why we see variations in the prevalence of HIV and STIs across racial and ethnic groups. And again, when we adjusted for socioeconomic determinants, it probably adjusted for about 30 to 40% of the effect, but certainly not the entirety.
Can I just ask, Rob, since you're here now, I mean, you've just come from the NHS Confederation, big conference. I mean, I noticed on the agenda that there was only one tiny little bit there on BME issues, which I thought was a pity, actually, whether you felt there should have been more on the agenda, more discussion about it.
So I think it's a good challenge. I mean, I think if you think about what we've just heard from the speakers, and I should say thank you for inviting me to come today, because it's an agenda that I'm very, very committed to. If you listen to what the speakers just described, you know, what we've got is a state of affairs which is shocking, but we're not really surprised. And I think we need to move to a position where we're both shocked and surprised that this is happening. I think our experience tells us, I've been tweeting some of the conversation, and people have been saying, well, is it going to be any different in a year? Is it going to be any different in 2 years? Is it going to be any different in 3 years? Because people are, I think, a bit worn down by trying. You know, Vivienne quite eloquently put, you know, how much progress have we made really, and what can we do to really make a difference? At the Confederation, what we've been trying to do is make this at the heart of the work that we do. And I think there's a trade-off. I'd be really good today to try and test with you. Is it better to do something separate, or is it better to make it part of every conversation? What Kevin quite eloquently put was that, you know, health inequalities and issues around race and discrimination go hand in hand. So do we talk about them together, or do we do it separately? So I think we did a session around BME and BME leadership through the BME network at the Confederation Conference as a standalone item. I talked about the stain that this issue leaves on the whole of NHS leadership in my keynote speech. But we need to make it something we talk about all the time. And again, I'd like to hear from people whether you think we need to do that because we have BME networks, or we should do that as a mainstream thing.
Nurinder, down the front here. And are there any other, and then there's one up there as well. If we've got 2 mics, we can put one in each hand.
There's 4 mics.
Oh, here, and then so if there's another mic over the gentleman there as well.
Does this work? Yeah, it okay, works. I'm Nrinder Kapoor from UCL. So I'll try to ask, if I can ask 1 or 2 questions of each of the 3 people who just, so Professor Fenton, just wondering whether road traffic accidents comes into public health, because that's a major cause of mortality and illness, disability. And the second question I just want to ask you is, to what extent do you think we can learn from developing countries? So for example, in India, there's TB and all these, so can we learn anything from how they go about dealing with these problems? And then Dr. Andrews, I was just wondering whether you think the Equality in EHRC, Equality and Human Rights Commission, has that let down the BME community, and do you think that that body has got a better role to play? And since Rob Webster is up there, as you may know, Sir Robert Francis, when he produced the report on whistleblowing earlier this year, had a major section on how BME staff were victimized. And if you're a whistleblower, you suffer. If you're BME, you suffer. If you're a BME whistleblower, you suffer even more. And there's kangaroo courts in NHS trusts where the disciplinary procedures are usurped by HR and staff are victimized. So do you think the NHS Confederation has a role to play in the overhaul of disciplinary procedures so that kangaroo courts that Sir Robert Francis described do no longer occur?
Should we start with the first one first?
Okay, so thank you so much for the question. So we don't have a road traffic accident prevention program per se at Public Health England. We recognize that it remains a public health issue. But what we do have are data and intelligence activities. So we look at the data, we collate the data, and we provide that data to our local stakeholders. But we don't have a prevention program at the moment. And that was a conscious decision in terms of how do we prioritize scarce resources on some of the bigger drivers of morbidity and mortality. So obesity, smoking, mental health issues, etc. So our commitment is to provide data, and we do that. Your second question about what can we learn from developing countries, I think is a brilliant question. And in my public health practice, I've been really privileged to work globally and to work in many developing and middle-income countries. I think there are 3 key things that I bring back to my practice now. The first is the importance of engaging communities. I think when you're in resource-poor settings, you have to engage and you have to empower communities if you're going to have any impact on both changing policies, advocating for policy change or services. And you need to have an empowered and engaged community in order for those services and the scarce resources to be used effectively. So that's certainly one of the areas where I think we do well here, but we have a lot to learn. The second is the fact that technology in many developing countries and middle-income countries have now leapfrogged. So in Africa, in many African countries, the penetration of mobile technology, the way we use mobile phones in many African countries for purchasing stuff, commerce, for banking, for doing financial transfers. There's a range of ways in which we're using mobile health in developing countries that we're not doing here. In England, we tend to focus on the use of apps, for example. In many countries in sub-Saharan Africa, the use of the technology to improve health is far more advanced. And then finally, in addition to community engagement, there's also something that I've learned in resource-poor countries, which is about the importance of investing in your infrastructure of community organizations and non-governmental organizations. And as we've gone through an austerity in this country, many community organizations are closing down, they're merging. And that has a real impact on our ability to develop and deliver culturally competent services for communities in need. And it's an asset that we have got to protect as much as we can in England, that as we go through the economic crisis, that we do not strip away the foundation that we have for engaging communities and supporting communities. And I think developing countries tend to have a value of preserving those infrastructures much more than I think sometimes we do here. So 3 lessons learned.
Very good. Andy?
The Equality and Human Rights Commission was a letdown in its idea, its conception, and its delivery. I mean, the whole conception of it tells us what the government's priorities were and how they see race. So you move from having a Commission of Racial Equality, which was very much about how do you get race and put race on the agenda, to a commission which now says we're just going to deal with everybody and doesn't deal with anybody. It's not just for black people, it's bad for all protected characteristics, because it's not a proper and a fully way to engage with the issues. And there's generally been this move post-race away from the ideas of looking at structures of racism. The Equality and Human Rights Commission embraces this idea of human rights, which is very, very narrow, very, very individualistic, which takes human rights away from the idea of structural inequalities, which just can't lead us anywhere positive. And so, in conception, delivery, and idea, we need to move back to having race at the heart, fundamentally understanding how important racism is structurally to how the society works, and then how it delivers all these inequalities.
Just on a small level, I was filming in a hospital the other day where one of the nurses had said that the hardest thing he found about having come to this country to nurse was the racism. And the chief nurse said, well, we have a zero tolerance policy. And I thought, well, what does that mean? Do you go and hoik that 90-year-old demented patient out of bed and tell them they're kicked out of the hospital because they've just called somebody, it said something racist? No. So it's been playing on my mind that from that level right to the top there.
And I think this is why when you talk about institutional racism, we often limit it to particular institutions. So we're talking about schools, talking about police, we're talking about the police. Actually, it's much broader than this, right? So a lot of, as you point out, a lot of the racial incidents and direct over discrimination comes from patients, right? Well, actually, that's because we live in a society which basically incubates and allows and perpetuates racism. And so you can't deal with that. You won't deal with that problem until you deal with the much more structural foundation of how racism plays out. And so you need, when we're addressing racism, we have to be addressing it across the board and not just inside individual silos.
Rob, you were asked to address the issue on whistleblowers, which I know is a particular concern for Narinda.
Yeah, sure. So I think one of our priorities, one of our obsessions in the Confederation is the culture, which we want to perpetuate in the NHS. And I could give you a load of great examples and statistics about how we've got some really fantastic foundations for our culture. So we have, I think, value-driven staff who are able to raise incidents safely in most organisations, who feel confident about that. And there's loads of evidence of that. So 1.5 million incidents raised by staff every year, 90% of people saying they feel safe to do so, and so on. But then I could also, like you, point to bullying statistics which are shocking and inexcusable. I could point to examples from the Francis report of whistleblowers being censured when they should have been supported. And those things are a stain on the leadership of the NHS, and they need to be washed out. So what we are doing is really 3 things. We've got a system leadership role, which is to say these things, to name this issue and get it sorted out. The second is to represent organisations with the system to say, look, what's the root cause of this? Do we have a blame culture? If we've got a blame culture, where does it come from? Is it a function of the fact that if you go to the Health Select Committee, say, or the PAC, you don't get treated with much respect when you're there? Is it because of the performance culture that we've got? What is it that's causing it? And we represent our members in that conversation. And then the third thing we're doing is providing direct support to people. So using the best evidence around what works in creating an engaged and open culture, and through the HR directors and NHS employers saying, look, we could do this. We could have world-class support for our staff to make sure they feel engaged. We could celebrate when somebody raises a concern which makes a positive difference to patients. And I think by doing those 3 things, what we're trying to do is take the good bits of culture, the good practice, and make them the thing that we do everywhere. I think that will take time, but what we've got to do is constantly come back to the issues of, if this is happening, it's inexcusable. Why is it happening? And let's address the root cause.
I noticed there was a whistleblowers helpline stand at NHS Confederation, but I wondered how many people in the NHS know about this helpline.
So what we've been doing is, whistleblowing helplines is one thing, isn't it, that works. What works much better, I think, is to have a culture where the chief executive and the senior team are visible, available, and have cultural ambassadors who support people. So people like Helen Donnelly, who was the original whistleblower from Mid-Staffs, embraced by Stuart Poyner in South Staffordshire, to say, come and help me so that staff know how to raise concerns directly with you and feel safe. Those are the kind of developments, I think. And what Stuart would say is, having had 3 calls to his whistleblowing helpline in a year, he immediately got hundreds of people talking to his cultural ambassador about the issues that they faced. So these things need to be addressed in very different ways, I think.
I suppose it's a bigger question in a way, but why do you think it is this, within the whistleblowing context, why it's happening? Is it institutional racism, would you say?
I think there are a number of things in the Francis report, aren't there, about why some whistleblowers are being treated poorly. And I think what people have said today is you've got to ask the question about, is there a race issue here? And are we questioning ourselves properly about that? Some of the research I've been involved in the past about attitudes and what's visible to white members of staff and black members of staff is really striking in terms of their perceptions about what's happening in conversations, what's happening in career, what's happening in performance. And what you see is white people feel that people are treated fairly and black members of staff don't. So I think we've got to look at these issues through the lens of ethnicity as well as through some of the other cultural lenses.
Did you want to add in?
Just to go back, when I did the South East Coast BME network review, and I asked a statistician just to look at the data, just to make sure, it's very simple stats, but just to make sure, because I couldn't believe the figures. I'd actually written in the report that actually this is probably due to the institutional racism. And he told me to take it out and ask the organisations why it was that we got this picture. And it does always amaze me, Rob, when senior leaders in the NHS say, we really don't know why that you have these results, that black and minority ethnic staff in the Francis report fared much worse when they whistleblew than other staff. It is the institutional racism, because there's been no other explanation for those findings over the years. And what we need to do is take that on board and just address it.
This gentleman down here, and then a hand up over there.
Hello. Rizwan Hassan, Dr. Hassan from Newham CCG. Thank you. Dr. Andrews' statistics were very interesting regarding the percentage of BME nurses and doctors in the workforce in the NHS. But my question is that it's not reflective of the board appointments who are actually in the making the decisions. And that's where I guess the real loss is. And there's no mechanism of monitoring that the board appointments are reflective of the proportion of the staff which are working, and without which I don't think that we'll be able to achieve the productivity and the efficiency savings of 22 billion pounds in the 5-year forward review. And I'd like your opinion how we can get the NHS watchdog bodies like the CQC, which actually goes and inspects organizations on one particular aspect, which is leadership, looks at the appointment process at various NHS organizations, and why the NHS boards are not reflective of the workforce and therefore are not one of the best. The reason why we have all this debate about productivity within a public-funded organization is that we do not know why the boards are not effective in getting organizations becoming more productive. And that's where the issues around the culture of organizations is also impacted, because we still have that glass ceiling, and we don't have the BME members reflected there in the board positions for making decisions.
Do you want to make a quick comment? Or?
Yeah, I think it's really important around that, because yes, you've got a workforce which is relatively diverse, and the academic and the board appointments are really important. Two things I'd say quickly is, one, even if you had representation on the boards, doesn't necessarily mean things would change, and I think that's important. We have to make sure that it's not just about getting people into those positions, because they may just be just as bad as the people in the positions previously, which is why I think that as you're going forward, it's about how do you build a collective network that goes from the top to the bottom, which can put pressure on those appointments to change, and then will also put pressure on the people in those jobs to do a better job. So I think that's important.
Thank you. There's another question. If you could keep the questions brief, because there are now a lot of hands.
My name's Jacinth from West Midlands Ambulance Service. I will keep it brief, but I also do want to make a point, which I think is really important. Just very quickly, representation at board. Having been a director of nursing, I'm now a non-executive. It's very, very difficult when all of the black staff are looking to you for salvation. You do what you can and influence where you can, but you are one person, and it's emotionally draining. It's just a point that I want to raise there. But there were words that were mentioned, shocked and surprised, and what will be different. BME staff are never shocked and surprised. It's kind of part of our everyday package. We do want things to be different. We do want things to be different. At Trust Board, we wheel patients in. We listen to their stories. We say, oh, isn't that terrible? And we drive forward change for patients, many of which are white patients that come to the Trust Board. We've got lots of research we've heard today. How many organisations are having black staff into the Trust Board to listen to their experiences? Because the research is great, it provides food for our head, but actually it doesn't impact on our heart. It doesn't touch on many people's experience. But my question is, Vivian gave us, as black staff, a challenge. My question is to Kihende and Rob, and I hope I've pronounced your name correctly, Kihende. If you were having a personal conversation with chief executives, Rob, I know you do that all the time, with chief executives and with board directors, with non-executives, what are you going to tell them to do? What are you going to say to them? What challenge are you going to give them personally and in their board of directors to make a difference? We've got the research. We don't need any more research. We've got all of that. What are you personally going to say in that coffee conversation? Both of you.
So my hope is that what we're going to do is shift from being, talk about this agenda as a deficit-based agenda to an asset-based agenda. So diversity, skills, experience, the assets that you have need to be brought to the biggest set of issues we've ever faced in the service. And if we do that, if we end up with a diverse leadership which brings all its skills and talent to bear, we will have an NHS which is free at the point of delivery and delights people in this country. If we don't, we'll fail. So my question to them is going to be, as a value-based leader in your organisation, how are you creating the culture where diversity is seen as an asset and you harness the power of everybody that works for you and every patient that you work with?
I think what I would say as a starting point, I would say that it's absolutely important that chief exec has to engage with the BME network. I think it's really important. It's not about one person going in and saying, well, these are the arguments, we want this, we want that. It's about saying you have to fundamentally properly engage with your BME network. They are going to lay out a set of demands, and if those demands are not met, there will be consequences. And I think that's the only way to do it. Because as I said, you can be on the right side of the argument for 500 years, and don't get any results. It's about how do you make sure that they are accountable to the staff, and I think that's about a staff as a collective rather than a staff, people as individuals.
We have a question here.
Good morning. Good morning, conference. Good morning, everyone. Alison Hewitt from Berkshire Independent Hospital. With reference to this young man's referring to kangaroo courts, I'm just wondering, Vivienne, is there any room on next year's programme where two of us could work together on empowering people to fight any accusation of disciplinary, any kind of form of behaviour within the workplace? I'm in the process of contacting several employment lawyers. I'm here because I'm on garden leave. So, is there any room on next year's conference, specifically as you yourself have had experience of these kangaroo courts, probably as much as I have, is there any room on next year's programme for a workshop and empowering people to fight within, empowering them to take these things on?
The truth is, Alison, I'm inundated with people that contact me because they know I've been through that experience, asking for my help, asking for my advice. 2 of which are in tribunal this week, 4 Indian doctors from Brighton, somebody in another part of the country, all of whom I've had to be there for them. It's not possible, Alison. As much as I would like to say that the network would be there and be your support in that, it's just hundreds. And in fact, about a year ago, we did actually approach the Society of Black Lawyers to ask if we could take out some insurance for the network, could we then help BME staff that were in trouble, and they would actually provide the legal advice, but it didn't come to anything. But there is a desperate need. I would like to sit here and say, yes, Alison, but we just haven't got that capacity.
My name, I'm Rachel. I work at King's College Hospital as a renal matron. My question is, I think the problem we're facing is historical. Recruitment is done from other countries. I'll give an example where some of these issues we face. They go and interview nurses who are very experienced from third world countries. They are brought actually not to fill the senior positions in the NHS. They come to fill in the junior positions, which are band 5s in most cases. And we are talking about these nurses who were sisters, even matrons, but when they come here, they are made junior nurses. And it's very, very difficult for these nurses to actually fit in the system where they were people making, decisions, and now they are junior nurses. And they know that some of the sisters that will be looking after them might have been in the service maybe for 3-4 years, and when they try to say something, they will think, oh, you are bullying your sister. And this is the problem. I think it's the recruitment they need to look at. Even with the doctors, I know we have some senior doctors from abroad who are never recognized as consultants, but they call them associate specialists. Thank you.
This lady. This lady.
Yeah. Hi. Can you all hear me?
Yes.
Right, okay, good morning everybody. My name's Julie J. Charles. I'm here representing North East London Foundation Trust, but more so I want to put to the board that I've just received a Lifetime Achievement Award for 30 years of voluntary work developing service users, BME, service user networks. Now, I think that we need to bring this back to service users. We're talking about staff, and I know the conference is about staff. However, I know that Vivienne has a passion around service users, the local, raw, grassroots needs. However, I think that what's happened over the last, it's going to be 10 years now, is that the government hasn't ring-fenced any more money to actually set up BME networks of local service users. I led, was one of the leaders on the Delivering Race Equality agenda some time ago, and there's no more grassroots money. Now, the money is there. The money is there somewhere, but someone's got to let it go and recognise that BME service users are desperate for that support out there.
Do you want to say something?
Very much, Julie. And it isn't just about staff. I agree, but a lot of the questions have been. And that's why I did approach the 3 chief execs, because this year was the year that we decided as an exec on the for the NHS BME network that we would start with mental health, and that's why we approached them. And going round the trust, Julie, and seeing how beneficial that programme was to service users was so humbling. And yes, the money, you say the money's there, yes, the support is not there, but I still believe that if we can get chief execs on board like we did in these 3 organisations, we will reach those black and minority ethnic service users.
So I think that's a great point. One of the things that we should look at very hard is what we've just done in terms of setting up the arrangements in Health Watch, local Health Watch, every trust becoming a foundation trust with members who are members of the public, who are governing the organisation. How are those arrangements helping this agenda? How are those arrangements ensuring that the people we serve are represented as governors in foundation trusts, their voices heard by Health Watch arrangements and organisations, that services are reflected in line with the joint strategic needs assessments that they're doing? So these questions about how are we hearing the service user, I think we've got to throw at the people whose job it is to do the work and say, how are you actually doing this in practice, and how can we help?
There's one microphone over there and another one there, and then if we can have microphones here. So the microphone over here.
My name is Maggie Harawa, and I'm from the Norfolk and Suffolk Mental Health Trust. And the question is to Dr. Andrews. And this is obviously with regards to students, because I was a student once. And I just want to say, because we're talking about racial, inequalities and issues of representation, students spend most of their time in placements. And we've had students who've been good, and we've seen how they've progressed. But towards the 3rd year, you've heard that the courses have been discontinued. So I just wanted to find out how universities are making sure that students are supported and throughout their training, and when they're ready to go into the NHS and face the issues that we're all currently talking about.
Thanks for the question. It's an excellent one, and I think you'll find that, again, as I was talking about this institutional racism across the board, it's pretty terrible, actually. Supporting universities when there's lots and lots of complaints. I mean, Birmingham City University has a big nursing training, and numbers of students drop out every year because they experience extreme racial abuse from patients and from staff as well. There's lots and lots of complaints, and all the evidence is it's not getting treated properly at all. There's no effective mechanism to keep people in, and people stop and people leave. So I think, again, this is one of those things you have to have a much more holistic approach to it, because you find these same inequalities that you find in the NHS, you find in universities as well.
So I'd like to thank you for that question as well. In Public Health England, because we're new, we've had a chance to really look at all of the organizations that were brought together to create Public Health England, and to really ask questions about how are we treating our BME staff. And there are a few things that we're doing, because we realize that there are issues of progression within the organization and retention of BME staff. A number of executives within the organization are taking on roles as race and equality champions. So we have specific areas of responsibility to challenge Public Health England on what we're doing for different staff groups. So there's gender, LGBT, a range of disability champions, different executives have a role for. We have a good mentoring program. We are deliberately looking at ways in which we can open the organization to BME master students, nursing students, medical students, etc., so that we can begin to create an environment that says, actually, we are open for business, and we really want to diversify the pool of talent that we're drawing from, and we want to ensure that you understand what we do in Public Health England. And then the fourth thing that we're doing is really looking at our data. And the data is so bad in terms of who are our staff, how are they progressing, what are some of their, how engaged are they, and what are some of the issues that they're facing with. So we're developing whole new measuring systems for the organization to help us to do a better job of understanding where we are and how we can improve. So there are a few things that we're doing in PHE, and we're really hoping that we can be an exemplar public health government organization that can say, we are committed to changing this, and here are some of the things we've done. And I know that there are trusts which are doing this, and other arms and bodies which are also being very proactive on this as well. So.
I'm afraid we're beginning to run out of time, so there are two people who currently have microphones. So if the person at the back there, and then you, if you could keep it very quick, but whoever's got the microphone up the back, yeah, thank you.
Hello everyone, my name is Titi, I work with SLAM. My question or my suggestion is to Rob Webster. I know there's this issue about race inequality without having to go back to the books and going through all logistics and wasting more time to address this issue. I think more than half of the NHS are making use of DataX now, where we report all activities. Why can't we include race equality activities as well and make sure that the secrecy actually inspects equality, raise equality issues as well. So then every NHS organization knows that one of the things that will rate the NHS is about the race equality activities as well. So I think that will really make more than half of us here feel heard, and that solutions will be created, because then you know that you've already logged in these issues and it has to be addressed before the inspection. So I think that will really solve more than half of the problems that we're facing.
Thanks for that. I think it's a great point. And if you look at the work that's going on through the Equality and Diversity Council and the Workforce Race Equality Standard, it starts with saying, look, let's get the mainstream issues and data right so that we can help support the right sort of culture.
Yeah, this lady here. And then if the microphone could go to Angela as well, please.
My name is Akina from Sheffield Teaching Hospitals. All the speakers have told us that the answer lies with us. Dr. Andrews said that power concedes nothing without demand. Could we use NHS BME network as the umbrella organization in challenging the trust we work in? Because collective action, in my experience, is always better and more positively received. And the second question is, who is going to monitor the race equality standard? Who is going to monitor that, and what happens to the trusts that don't adhere to that?
My name is Cynthia Colston. I have one question, which is for, I think, the whole panel. Can you hear me? We've heard the arguments, and for many years now, we've had several initiatives that's supposed to address this agenda. We're still talking about it. A few years ago, we had the HCC, which had race equality standards in race equality standards in their examinations. That didn't deliver. We also had the watered-down EDS for race equality, followed by the EDS2. That hasn't delivered. What I'd like the panel to tell us is we are not optimistic about the new res that's come in. And I'd like you to tell us whether you really think that that will deliver race equality in the health service.
Thank you. There are a number of questions. Sorry, I'm trying to put them all together. One of your questions, I think, could almost be asked at the next question session when we have the CQC up here who has part of that responsibility. If you don't mind asking it again at the next one, but certainly there are other, if we come along the panel, if you want to, Rob, start off.
So I love the question about is the res going to be the thing that makes a difference? So it's not the whole answer, is it? So I think the only thing that's going to drive this agenda is leadership and just a recognition that the NHS is made of people. It's not made of drugs or buildings or kit, it's made of people. It's made of you. And what you need is a set of leaders who have the right values who are going to drive this agenda, because it's the right thing to do for patients, it's the right thing to do to tackle the issues that face us, and because they're held to account for it. And what the res does is gives a platform to measure and hold to account. But it's necessary, but it's not sufficient. So you need the leadership alongside it. And I think we've got a cadre of values-based leaders who are going to push this agenda very hard. And anything I can do to keep doing that, I will.
I make it quite simple. No form of policy, national policy, local policy, institutional policy is going to deliver racial equality. It's just not. And you can give example after example after example, and it doesn't work across any industry anywhere, right? What will deliver or can deliver is collective action, like the lady said here. It's about collective action. It's about realizing the power that you have. It's about when the question was raised, who is it that should monitor the res? It's the BME network. The BME network should establish itself to monitor this. And when you find out how terrible it is, you should make clear demands and have clear consequences for that. You represent 1/6 of the workforce. That is power. Power always lies at the bottom of the grassroots. And then with that power, you can make those significant changes. And that is the only thing that will ever has and ever will deliver race equality. And also connecting that broadly outside, right? So we have the grassroots communities outside, we have the patients outside, we have the people who are experiencing these inequalities, not just on a staff level, but on a delivery level. And it's about bringing that collective together, making a clear set of demands, and then making sure those demands are ensured. You have the power to do it, you just have to seize that power.
So I agree with my two colleagues that both leadership is going to be critical as well as collective action. I think two things I'd like to add to the mix. The first is the need for data and transparency. And we need to ensure that we have the right measures that are tracking organizations. And I think we need to make it transparent. And if it means that we're going to be name and shaming organizations, perhaps that's what's needed to drive that sort of collective accountability for where we need to go. And my second point is around accountability. I'm not sure if this is the same in all other trusts and arm's length bodies, but as an executive in Public Health England, I now have a diversity target and a diversity domain that I have to report on my activities as an executive, as a leader within Public Health England. And I'm held to account. What am I doing in terms of a diversity champion? What am I doing in terms of the programs that I'm delivering in terms of reducing inequalities? And what is my staff engagement score? And how is that related to the work that I'm doing? And what am I doing to improve that staff engagement score? And there's no way that I can be rated exceptional unless I'm doing very good exceptional on all of those domains. And I think it's that type of accountability supported by good data. And it's not just the responsibility of BME executives because there's so few of us. It has to be across the board, and there needs to be that culture and that leadership as well. So.
Rob, you are right about leadership, the system leadership, but Nigel Criss, in his 10-point race equality plan in 2004, showed clear leadership around this agenda. And last year, Nigel Criss said that actually it was worse now in the NHS than it was when he showed leadership on this agenda in 2004. The leadership on its own won't deliver it. It is the collective. And if you want the NHS BME network to create that collective, then we need you to stand with us and establish your local BME networks, and we will monitor the delivery of that standard.
Angela, just one.
Angela, it's on, yeah. Angela Hillary, Chief Executive, Northamptonshire Healthcare Trust. My question is to Vivian and Rob, if I may. So I want to take it back to BME and mental health reverse commissioning. Vivian, you've been the advocate of this particular project, and I'm really pleased to say we've been a real player in it. But do you feel nationally you're getting now the support to take the impact of this further That's the question to you. You're clearly advocating, but are you getting support from others now to do more? And to Rob, the question is, how cited is the Confed on this particular agenda? And how can we use what the three organisations have done to challenge the leadership within the NHS, be it provider or commissioner? Because clearly we've got some work that's already there, ready to share.
Vivian.
The answer is, Angela, no. Nationally, I'm not really recognised by the system, and I think it's something to do with what I say. You know, last year, the NHS logo, we were told we couldn't use it. The fact that we've been asked to do, like tonight, for example, we've been asked to host Sam King, and that came from the NHS England. Ruth Passman, she's here, and that's a real honour. But in general, no, we're not recognised.
So I think that one of the jobs that we've got at the Confederation is system leadership. Another one is representation. And I think we can take a great deal of confidence that if you look at the mental health agenda, the mental health network and the leadership within that have really driven the idea that we need parity of esteem for mental and physical health. And I think that if you look at the speeches, the conversations, the policies, the rhetoric, mental health is mentioned constantly. So on the one hand, you could say, well, we're being successful. On the other hand, if you look at expenditure in mental health services last year and you strip out specialised services, it's gone down in an environment where it's supposed to be a priority. So I think we can take issues like this and we can use our influence to get them in front of the right people so they get adopted and delivered. And don't forget, NHS clinical commissioners are part of the Confederation too. I think it's beholden on using people like Vivienne and others to keep that voice real and to get that influence right. And you know, I think that she's got a very clear, profound and important voice that we've got to harness.